in our second day of the operationalization of One Health in our region. I'm going to welcome all the participants that are here on site and everyone else that is connecting virtually. Welcome to the second day of this meeting. I want to briefly summarize everything that occurred yesterday and today. So I'm going to just briefly speak about what we addressed. So we held 2 panels and a tabletop exercise. The first panel spoke about challenges faced. I'm going to briefly speak about what each of our presenters and panelists spoke about. And Dr. Sanchez from Pejo spoke about the integrational vision to be able to link public health and zoonotic diseases. And among the different challenges, there are initiatives in the different countries, but we lack an overall structure, formulating adequate questions, and being able to ask that right question or what anyone else could contribute. With regard to OMSA, Katia Martinez spoke about searching for multi-sectorality and coordinating tasks and taking action in the different countries through initiatives and tabletop exercises. At the FAO, Dr. Marundinga spoke about implementation of a strategic framework and trying to fill the gap as to how to do that. And she spoke about the cost-benefit analysis as well. Among the recommendations was to identify priorities and the academia and the private sector as partners to be able to operationalize this context. As part of UNEP, Mr. Ivan Fabricio Canaval spoke about a global framework and the triple planetary crisis, speaking about climate change, contamination, and loss of biodiversity, and knowing how to complement this instead of replicating efforts and attaining joint funding. Among the work was done was identifying priorities, the role of the civil sector, and intersectoral priorities. As part of OLEP, Natalia Sedel spoke about the lack of political will, the absence of policies, and the difficulty in being able to share data, integrate efforts, and make decisions based on that data. She spoke about inclusion, equity, and access, and operationalizing this has to be perceived from different stances, from a top-down perspective, and that the grassroots organizations have to play a role in this. Among her recommendations was to share success stories and use pilots, and she spoke about the 4C: collaboration, communication, continuity, and community. And Diego Quiroga spoke about the close relationship between plant, soil, crops, healthy food, and caring for the environment, and that processes have to be strengthened to prevent pest outbreaks, and we need impact indicators. As part of the recommendations, we spoke about that. We spoke about adding this to the agendas and holding more interdisciplinary meetings of this nature, and finding new technologies with regard to One Health. And then, after the first round, during the second part of the morning, we spoke about experiences and success stories with One Health, reminding us about Canada's achievements. They spoke about a group of experts in Canada that analyze how to mainstream the focus of One Health in a more holistic and collaborative manner that is consistent and coherent. And Colombia spoke about in Colombia, Natalia Cedia spoke about empowering women and how that could lead to strengthening other processes, and that gender and One Health also go hand in hand. And a good practice is to invest in this because it is meant for all of society. And in Central America, we heard from Alejandra Diaz and Sacha Treyes, and they shed light on how this territory is a uh, socio-geographic territory and converging different action plans through projects and changing the entire paradigm uh, and attaining resources and activate non-epidemiological emergencies in a One Health approach. The United States experience was explained by Dr. Heather Fowler. She spoke about seeking stakeholders, strategic partners that we need to create champions, One Health champions, let's say, and that we have to share the story. We have to share, we have to speak about our intentions, initiatives, and events. And we have to think out of the box. On the other hand, Argentina's experience was revealed through Dana Guillen's. She detailed the public-private aspect that needs to be considered. She mentioned the SDGs as well and how they play a role. So she mentioned the goals that now exist, and we can use these goals to operationalize the One Health concept. Lastly, as part of the experience of academia, Armando Huet from Ohio State, the Ohio State University, spoke about creating protocols and procedures uh, so that this focus will be operationalized, incorporating the human element and education as well. This means moving from theory to practice. During the afternoon, and here are the 6 more important parts of the afternoon session, where we sought collaborative efforts to guide identifications of needs and intersectoral actions, creating networks and committees, work groups that are permanent. We recommendations were made that organizations such as ICA that work in this endeavor could help to a certain extent operationalize this. The economic component as well is important, as well as being able to motivate donors. We have to raise awareness, appropriation, and disseminate this focus to make sure that it'll be sustainable through time. And this is done through systematization of partnerships. And we have to use indicators, the SDGs, to be able to monitor and create methodologies and conduct a comprehensive focus based on policies that already exist, plus guidelines and protocols and alignments. We have to also develop skills at all levels, from the consumer side to the policymakers or decision makers. So we begin on this note. We're again going to have another panel representing a whole group of other countries and share their successful experiences with us. And during the afternoon, we're going to listen to international organizations, and they're going to present their strategies with regard to operationalizing the One Health concept. And we will hold our afternoon tabletop session where we will speak about governance and One Health. To close my introduction this morning, here at ICA, we are already working on a One Health focus in a kind of inherent manner. We have 10 experts where we have agricultural engineers, veterinarians, food technology experts, and this is an example of the multidisciplinary access that we require in this type of effort. As a manager, I work always with different types of sectors, not only vets like I am. So we have to think out of the box, yes, and continue onwards in expanding this and embracing this concept. So welcome to the second day.
Muy buenos días a todos. Para los que no me conocen, mi nombre es Eric Bolaños. Trabajo en el programa de Sanidad Agropecuaria e Inocuidad de los Alimentos y de Calidad, aquí en la sede central del ICA, y los voy a estar acompañando en estos próximos 75 minutos, en donde damos inicio formalmente al proceso de diálogo y discusión con un par de rondas de conversatorios. En una primera instancia, experiencias e historias de éxito en una salud. El día de hoy iniciamos el abordaje del evento desde la óptica de acciones conjuntas. Para ello, la primera sesión del día de hoy tendremos una serie de experiencias de éxito en el tema o en el enfoque de una salud. Les recuerdo que las sesiones de esta mañana se implementan bajo la modalidad virtual y se cuenta con interpretación simultánea en español, inglés y portugués. Por lo tanto, invito a los participantes que están en el formato virtual a que vayan escribiendo sus preguntas en la plataforma electrónica conforme vayan surgiendo. Así va a ser mucho más fácil la gestión de las mismas. El objetivo de esta primera sesión es compartir experiencias nacionales o regionales exitosas de implementación del concepto de una salud, que ayuden a identificar factores de éxito y factores desafiantes, que ayuden en este evento a visualizar la implementación del concepto de una salud. Para lograr este objetivo, tenemos a 5 panelistas, los cuales podrán compartir con nosotros una o dos experiencias en un tiempo máximo de 10 minutos, para posteriormente entrar en un proceso de comentarios y preguntas por parte de los delegados en formato presencial y virtual. Quiero así, por lo tanto, invitar a que nos acompañen aquí en la mesa principal al señor Manuel Sánchez, a Jaime Romero, Roberto Navarro, Gavin Peters y Marcela Rodríguez. Gracias por estar con nosotros en esta sesión. Repito nuevamente que cada participante tendrá 10 minutos, un máximo de 10 minutos. Les confieso que seré estricto con el uso del tiempo, esto con el fin de poder equilibrar la participación de los conferencistas y las preguntas de los participantes. En ese sentido, faltando un minuto,
And the Q&A session.
estaré haciendo alguna seña.
So I will be I will let you know when your time is up. So what elements or information do we expect from you during this discussion?
Tuvieron con ustedes, pero les recuerdo
But
que sería importante
let me remind you, it will be important that presenting the success stories include this information or part thereof. What was the problem or situation to resolve? Why is it the example of the One Health focus implementation? What results were attained? What were the participating stakeholders? And what were the main challenges that you encountered during this process? And what were the successful achievements? So the order of the presentations will be as follows. First, Manuel Sanchez, then Jaime Romero, followed by Mr. Navarro, Mr. Peters, and Ms. Rodriguez. Let's begin with the first speaker. And Dr. Manuel Sanchez has the floor. He's a vet, coordinator of the epidemiological department of PEJO WHO, with more than 20 years experience in public health and animal health. He's also active with WOA, PEJO, and WHO, and is also active in academia. He's worked throughout America and Africa and has a master's in epidemiological studies and public health management. Thank you so much. Okay, my 10 minutes are beginning. Okay, I suggested 2 examples, which I believe are diverse. Good morning, everyone. The first experience has to do with an intersectoral consultation process we did on the avian flu. Now, this was the region was facing an emergency situation with regard to the avian flu. And what we did was convene representatives from different countries in public health and veterinary services together with reference labs, vet labs, and experts from international agencies and PEJO collaboration centers. This was our framework. And what we wanted to do was share success stories and challenges in addressing the intersectoral manner we addressed the avian flu. It impacts the avian flu, that is, it's zoonotic disease, and it has an economic impact that's huge and food security because it impacts production with regard to domestic animals. But it has a zoonotic component that could be fatal if there's a resurgence of the virus, and it could even lead to a pandemic, we could say. So it's important to, address this in a One Health focus. So we held various work groups or organized various work groups, and we addressed 5 main areas in an integrated manner. One had to do with surveillance, response, the coordination mechanisms that exist, joint risk analyses, and joint communication efforts. So, and this is published, but our conclusions basically were that at a global level, there isn't a structure per se that's an official one that encompasses this, but there are some recommendations for joint work in this regard. So if an emergency occurs, that's when we need to contact other sectors. For example, if there's an emergency on a farm, that involves health. And then, but there isn't a contingency plan, let's say a protocol that we have elaborated, not yet. And working together on reducing risk is a great challenge as well, because again, there isn't an official methodology to follow or protocol in place. We haven't identified the common target audiences and challenges. So it's an opportunity to work with different countries in that regard. And examples that were identified, for example, the backyard farmers, for example, these are citizens with that are poultry producers, backyard farmers, and it's a way of propagating the virus, and this has to be addressed. But they play a role in animal health, and these individuals also run a risk from a public health perspective with the possibility of outbreaks. So there's this dual message we have to convey from an animal health perspective. These individuals have to acknowledge or recognize or know how to detect diseases in their backyard poultry flocks, and then convey that information to prevent public health emergencies. And this is a second message. These individuals have to know how to protect themselves. They have to use biosafety protocols when handling their birds and know where to go in the event of their becoming ill. So this could be an occupational risk since they're in contact with birds. So there are 2 different messages, but with the same target audience, human beings. And this is just an example of what we've addressed about how to work together to help this ultimate or this final target audience. Our efforts had a regional scope. We tried to include participants from different areas of the region. And after that, we identified opportunities that we had to work on. This is a consultation document that is published. We can identify, for example, different contexts, uh, and then opportunities and examples of success that were identified. After that, we replicated this workshop last week, and on a sub-regional level with the OAS as well. And we are also including environment and the private sector as a second step. But since there are so many lessons learned, it really opens up the doors to technical cooperation at PEJO to identify opportunities and where we have to work to achieve intersectorality. The second example I'd like to mention is risk classification for cutaneous leishmaniasis, which there are reservoirs in wildlife, and this impacts different individuals in a different with different severities. And we use data that's existent, big data available, uh, and we were characterizing different variables, socioeconomic variables that were determinants. So this is it's CL basically, to characterize leishmaniasis, cutaneous leishmaniasis. And that's important because One Health doesn't only address public health and the environment and food uh, security, or food safety, pardon me. We want to also leverage on technology, vegetation, satellite imagery, uh, and use different forms of education and in sanitation, for example, and also social constraints that we face in this regard. And this is used with modeling, mathematical modeling, to identify common clusters where we know there is more risk of falling ill with cutaneous leishmaniasis, CL. And this is an article that's available in Spanish and English. And it's important given the implication, the technical complex characterization of the disease, but also the consequences that it conveyed. And after that, we were able to identify throughout the region areas where there's transmission of CL. There are areas in the region that do not have this transmission. So basically, it covers Central America and South America where there's CL transmission, and it guides public policies as to how to address this. In Brazil, for example, the project was continued to and trickle down to the municipalities and better characterize what's happening and have different warning systems in place and to be able to gather real information or true information, or data regarding the disease. I think this is an important example because it's a zoonotic disease and it deals with wildlife reservoirs, dealing with mammals. We have vectors, and we also have a serious public health issue that impacts rural areas. And it's tied, and it's an area where it occurred in an area of accelerated deforestation. And different communities were involved, and that's where the contact with the vectors is higher. And also mining areas were impacted, and that was included in the study. So based on that analysis, we can develop proper public policies. My time is up.
Well, the recommendations for me, this is an example to follow. We are replicating this for other diseases. The methodology is published, there are databases, and this is a very important publication for me when I come to think of how to guide public policies and work with the existing information. Thank you, Doctor. Thank you very much for your good time management. In the presentation, you have shared very interesting figures and data. I am sure everyone is taking note for the questions later. Now, the next presentation will be headed by Dr. Jaime Romero, a veterinarian doctor specialist in food safety and animal health at ICA. He has a PhD in different areas and has all kinds of publications on animal health economy, designing animal health programs and agricultural policies and veterinary public health. Doctor, please. Thank you. Good morning, everyone. I am glad I spoke after Manuel. He has shared very interesting things. So those of you that were still sleepy are now wide awake. There's a presentation I would like to, or some information I want to share with you. Why am I a veterinarian? Well, because I am the son of a farmer. I am a veterinarian because for me, diseases were mysterious. I learned to produce with my father agriculture and animals. I had the fortune of having many opportunities, among these being here. So those are things, of the things I want to share. I have selected 2 experiences and a couple of recommendations. This is a position through which I want to convey that One Health is not a what, but instead a how, up to you. The problem I will share with you is the parasitic disease of highest global impact, and that is the main cause of the acquired epilepsy. 2.8 million dailies per year, between 2.5 and 8.3 million people that are disabled for a lifetime because they could have this sudden epilepsy due to psychosis and neurocytic. This is a problem that 40 years ago, the International Task Force considered it as one of the 4 diseases that could be eradicated from the planet because it could be simple, easy to manage. So easy to manage that developed countries no longer have it. Basically, how to manage this? Well, we learned when it became endemic in a rich Jewish population in the United States. And it opened the door to think of this differently because Jews do not eat pork. This is a disease for the wealthy, not for the poor. And that is the problem. The recipe was very simple. Well, take basic sanitation so that swine are not out there walking freely, so that people do not leave their wastes out in the air, open air. And as Natalia said, it is not just gender here. We must put an end to poverty. However, why do we have One Health? And why am I using this example? Because unfortunately, we do not have a prescription to eradicate poverty, and basic sanitation is not easy to take here and there and everywhere. So what? Do we wait until we eradicate poverty or until we can cover gender equality to fight these problems that could generate the impacts I just mentioned? The response of a team that had been working on this for more than 20 years, an interdisciplinary team, which included the creator of the AIDS test. He said, let us do something. Well, we can eradicate the problem. That is why the Linda Gates Foundation gave them a bit over $20 million to generate a strategy for elimination. And I was the manager of that program. Quite a privilege. And the task was to prove that there is a interruption of the transmission efficiently in a large portion of the world. So they selected the project before I became its manager, Northern Peru. They selected Northern Peru. We worked with medical intervention. We had ofendasol for swine, mecondamida for humans. We had a vaccine, tells 18, produced in Australia by Marshall and Towlers. The diagnostic tests had already been developed by them. There were 3 rounds, designing the strategies, using the same tools, hoping to eliminate it. And finally, we upscaled it and we reached more than 80,000 people, more than 55,000 swine. We eradicated the disease and we maintained it that way for over 1 year. Outcomes. Manuel has that experience. That is the difference of Jose with so many professions, agronomists and everything. That is why One Health is part of my essence. I have also had to work with veterinarians too. Working with doctors is not easy, right, Manuel? Those are from the health sector know that. Much less with doctors that are those that invest that diagnostic test. Just imagine working with all these geniuses that the one that developed the gold standard. Okay, the challenge is how to put all of these people together. But we did it. The knowledge and expertise was there. I want to share this experience in the last 30 seconds. I wanted to say, there was a first conceptual test worldwide. Yes, they were right. They could be eradicated. It was the best strategy. It can be replicated, but it cannot be implemented because there are things missing. The economic analysis was missing to prove that it was economically viable. If we have $20 million to work on research on a site, well, great, wonderful. But we were missing the political intervention. And the committee was created because this group came to advise. They were called upon by everyone, WHO, to share their prescription, but it is not yet enforced. Sulfendazole is not in the territories where there is cysticercosis, and we had to work with pharmaceutical labs specifically for this. The vaccine is not available. So there's so many barriers. And this has not become a reality. And let me share now the second experience. The second experience is somewhat different. An experience based on another problem. A problem, and this was done here at ICA, a problem where COVID-19 brought public attention to One Health. That is why we are here today. There are structures. It is not they are absent. There are many zoonosis control, interdisciplinary teams and groups, all kinds of experiences. But after we work in these committees, we go back to work and everything becomes fractured. Okay, and basically nothing really happens. So I said, okay, if I am challenged to action and our DG sends us to take action, how can I go about acting? Well, first we have to bring them all together, but I cannot be dumb enough because thinking that my problems are the same as Roberto's. No, Roberto has other problems. So we developed this process of identification of problems and identify how we could bring these all together. And we did this with our specialists in the 5 countries of the Andean region. We started to understand it could not be top down. Great, what we do. Great, the quadripartite. Great, everything we know about One Health, top down. Environment, what are your priorities? Only environment, each one of the 4 sectors. What are your priorities? We passed these through the filter of interdependence. Those that were interdependent go up in priority. Then at the country level, we force them through methodologies and tools to interdependently, the 4 sectors select one. And then at a regional level, we did the same. Very interesting. The 3 selected regionally as priorities. One is the priority in environment, water resource management, by the way. In agriculture, safety. And in health, rabies. Very interesting. And in this last minute, I would like to share the message of that experience. What did I learn from that experience? I want to share this with you. It is naive to believe that everyone will work on my priority in the same way. Secondly, we can, if we do it collectively, to ensure that the priorities of others can appear and become priorities. What are we missing in all of this? What did we miss? Well, if one region did it, why didn't the other one? Well, they no longer have resources. You're not implementing that. It was just a project back then. And it has to do with something becoming sustainable, reaching the decision makers. End of the project. And at the delegations, many of my colleagues and those that worked on this project may say, Jaime is responsible for that because that did not continue. At the end, the project came to an end. I turned in my report and I wasn't given other tasks. There are many processes, but in the lessons learned, I will share a series of recommendations based on these experiences. Thank you. I think I took 10 seconds from Manuel. I'm sorry about that. 25 to be exact. But we're doing well time-wise. 25 seconds. Thank you, Dr. Jaime Romero, for your excellent presentation. And now, the third speaker, we have the pleasure of counting on Dr. Roberto Navarro, a veterinarian director of the Mexican U.S. Commission for the Prevention of Foot and Mouth Disease and other exotic diseases, animal diseases, broad experience in epidemiological surveillance and of exotic and emerging diseases, as well as in the identification of diseases at a regional level and in emergency programs related to control and eradication of diseases. He also has experience in handling veterinary situations in cases of emergency or weather climatic phenomena nationally and internationally. He has many studies published, many publications. Go ahead, Doctor. Thank you. The truth is it has been difficult to be in this forum with all this information generated and compare it to what I have. I believe that to be at this meeting is allowing us to see the evolution of things and go back into history. I love history. When we were talking about the physiopathological determining factors of clinical effects, and that led to the epidemiological determining factors, and we used epidemiology that way for a long time. But the object of the social determinants or determining factors have to do with the epidemiological ones, and that is the objective of the story. And we could go back to prehistory and why we are here. We must understand this because the animals that we see here, horses and cows and chickens and swine and all of these arrived because of historical reasons that are not a part of our present, but are part of our food system and are part of the problems that we have with the emerging diseases. And I will share an experience dating back to 1993 on the coast of Chiapas, Mexico, on the border with Guatemala on the Pacific coast, with the strain Venezuelan equine encephalitis. This we have been known ever since the 1920s and 30s that caused a lot of problems in Venezuela, Colombia, Ecuador, Trinidad, and that under unclear conditions because of a poorly inactivated vaccine. It came to Guatemala, got to Mexico, and caused more than 50,000 deaths of horses. More than 25,000 people were ill. Many died, and many were left with neurological disturbances. It got to the United States, where they had a series of emergency actions. And by chance, the United States already had a vaccine developed for the Army against that strain, causing problems in people, so they could not use but used with horses, well, it could protect the horses. And that is how the disease was controlled. So that was back in 1969 to 73, and the Venezuelan equine encephalitis came to an end. Then in Chiapas in 1993, horses started to die, so we went to investigate. We had no idea of what it was about. The lab said that the mice they were inoculating were dying, and they saw that it was the Venezuelan equine encephalitis, but they could not determine which variant. So the first thing we see is that the first thing we saw, we had no diagnostic of this encephalitis, a new disease. We had no idea of the impact it would have. When this was reported internationally, trade was closed down. All international agreements and PAHO and many others, the European Union, went to see what was happening with the appearance of this encephalitis. And we did not have too much information. We had 40,000 doses of these vaccines that were under protection because vaccination had been ceased 2 years ago. So we had to go to an emergency operation and vaccinate. And after a few months, we controlled the outbreak. On what happened? Well, we were in contact with the Ministry of Health. They came, basically, they wanted to kick us out. This is our problem. We will handle, we will not let you do anything. And we have come to fumigate, and we will tell you where the horses are. We had no idea of what vectors were involved, whether the vaccine would protect or not. There was a complete division with the Ministry of Health in how to handle the information. Well, the outbreak was put out finally. And I said, well, this is the end of everything. They stopped exporting horses. What a big problem. So we wanted to investigate. We were charged 1 peso for capturing mosquitoes. We had no idea about mosquito traps and anything like that. So I contacted the people at the people from the National History Institute in Chiapas, and we started to capture bats and mice to see where the virus, the virus of this enzootic and Venezuelan encephalitis came from. We worked with the University of Maryland and the University of Texas in Galveston to study the areas of outbreak of this. And we had another outbreak on the coast of Chiapas. But working on this research, we were able to understand and if this is published, if you are interested in knowing about, we wanted to study the reservoirs. Now we have entomologists in the commission. We have mosquito trap systems, and we can study transmission. So all of this led to a whole technology that helped us later identify before anyone else the Nile virus in Tabasco, in Raven. There, everybody was studying how that was going to arrive, but the veterinary services we found it first. And we generated publications, and that led our laboratories to have virus sequencing areas, all as a result of identifying a disease that has allowed us, for many other problems, to have much better coordination with the Secretariat of Health. Now the relationship is much closer. Back then, we were requesting humans serum, and that was prohibited because aside from dengue, nothing else happened. And we were able to demonstrate later that there were many people that with this encephalitis, we saw that a mutation of the virus was causing the infection of a different type of mosquitoes that were distributed more widely. And they had changed the circulation of some rivers, allowing the mosquitoes to adapt to other conditions. And all this integral work and scientific knowledge has led us to have greater transparency in the work we underway. So this is giving us an opportunity for students of masters and PhDs work with us, and in agreement with the universities, and for them to go study abroad understanding disease ecoepidemiology. We are working with avian influenza, vesicular stomatitis, and with different arbovirus, because we have the ability now, both at the laboratories as well as with the field staff, to go ahead with this. We have shown that the vaccine we have, that we were producing a strain AB, does not protect against 1E, which is the one that had appeared in these emergency. And what else? Many other things. So we have decided to change the vaccines under development. And the work with One Health is ever more integrated with all of this. We have quantified a zoonosis that has been, may be interesting. So we immediately inform the Secretariat of Health so that they can activate their surveillance systems. And with avian influenza, in their own surveillance system, they have the coordination with Senacica to identify the viruses, and they have everything all set up at their laboratories to do the influenza testing, if it is H5 or H5N1 or H5N2 or H7N3. So there is greater integration, the same with the Secretariat of the Environment that we are working ever more closely with. We train them also on sample taking and how to dispose of carcasses if necessary. I believe this has been a very interesting experience and took us from basically knowing nothing during an emerging disease to now have a technological package to address these diseases. Thank you. You saved us 30 seconds. Great. Oh, shucks. Thank you very much, Mr. Roberto Navarro, for a very interesting presentation. We will now hear the fourth speaker, Dr. Robin Peters, veterinary doctor, executive director of the Caribbean Agricultural Health and Food Safety Program, CAFSA, specialist in animal health, with great experience in regional disease control and prevention for diseases of animal origin. Doctor, go ahead, please.
Yes, and thank you. So, like my colleague, I can speak Spanish, but I will speak in English. Let's do this by the show of hands, all the veterinarians in the room. Okay, I think that's the majority. On this panel so far, we are 4 veterinarians. I don't know if all of us are veterinarians. I wanted to share talk about the One Health concept in the Caribbean or in CARICOM region, which is 50 member states, mainly English speaking, and we have Haiti, which is French, and Suriname, which is Dutch. And then we have 5 associate members. So these are all English speaking countries. Now, how is One Health operational in the region? The 2 cases I'm going to utilize to show you is where there was a program to create, it is called One Health, One Caribbean, One Love, and where they trained 20 plus One Health experts or champions. And Dr. Aksha, that is right there, is one of them. The majority of those were veterinarians. And we included, there were, I think, some other medical doctors included. But from the problems we're having is that One Health in the region, and I think, may I dare say globally, is from a veterinary perspective, and then we try to include, or we include the other professions or the other sectors, such as the medical sector the environmental sector. And we hardly even include the plant health sector. Now, of recent, this has been one of the our objectives to include all of these other sectors into, so that we can collaborate and integrate them into the One Health concept. That was a success in the region, in that program to develop these One Health champions. What has happened subsequently? Each member would have returned to their country, but can you say that the project and its successful implementation and the continuation of that work is being carried out? I would say that is to be assessed and see how effective it is in that creation of those experts and in the work that they are expected to do to champion One Health in the region. It is not institutionalized. And we operate, the concept is being touted, it is being, you hear there are seminars that we may organize, there are workshops we may organize on One Health, but it is not part of us. It is not each profession that is integral to the function in a One Health aspect do not operate like that. Our medical doctors, our colleagues, they do, when we are to take those actions for it to operate as a One Health, it doesn't occur. For example, you may have cases where you go to the hospital and they're required then to report that back to the other sectors, like the veterinary sector, if it's a disease that is of animal origin, like leptospirosis. They may treat the patient and then that's it. That's it. There's no reporting. That doesn't flow back to the veterinary sector. In the abattoir, for example, the inspectors may detect tuberculosis, but then that's the end of that case. There's no reporting back to the veterinary department for them to then go and follow up on the farm where that animal may have originated. So this is the practical aspect of how it's being, how it's operating right now. And so what can we do to ensure that the One Health concept is in practice and not just these nebulous concepts that we are promoting? When we looked at the definition yesterday on the board when we were doing the exercise, that's so long, and it spoke of integrated and other aspects of the concept. In practice, that doesn't happen. We don't include the environmental sector. And when we try to work together with them, it's like an afterthought. So again, from a regional perspective, we need to have this institutionalized for it to become a success. It is difficult when sectors, you want to bring them together. It's a devil's own job. We normally say, if you want to bring two units together and tell them they have to do this work together. An example is in Guyana, they wanted to move the veterinary public health unit when they were creating an agency that was dealing with animal health in general. They wanted to bring the veterinary public health unit into the new agency. The veterinary public health unit is in the Ministry of Health. It didn't happen. They just refused to and say that they will move. If that is not done by legislation, and it's one of the things that I pointed out yesterday, then or your impetus or wanting to promote One Health, it is going to be based on the goodwill. And honestly, we cannot deliver if we are going to be only basing our actions on the goodwill of our other colleagues. be it from the veterinary sector or from the human sector or from the environmental department. My other case I want to share with you is when there was COVID. You saw where it forced the various sectors from the veterinary sector and the human to work together. In this case, where there may have been PCR machines in the veterinary laboratories, and they were mandated, told, you have to send this to the labs for humans to be able to process the cases. So they had to move, send their technicians, then to work to be able to do the diagnosis for COVID. In Guyana, that is what was done. But it was not an institutional arrangement prior to COVID, where you would need to move your equipment and supplies from the veterinary laboratories to the national diagnostic laboratories for human disease. So that was an example of where they were forced to work in a collaborative One Health manner to respond to a specific disease. What that is showing us, because you are removing a capacity that is in your veterinary section to be able to respond to a zoonotic disease. What this is showing us that if we institutionalize the One Health concept and have it arranged by legislation, by protocols, by procedures, then in practice, that will become a standard operating procedure whenever we are faced with these outbreaks, regardless of the source of them. So in conclusion, I would like to share some of the recommendations that were as it relates to this. For example, in the region, we need to bring all of the Caribbean, the One Health practitioners. We need to bring them together in some form of a workshop for them. Identify One Health champions per country. And while it is a common concept in the veterinary fraternity, we need to work with our other colleagues in the human and plant health and environmental health departments. Thank you.
We would like to thank Mr. Gavin Peters, Executive Director of CAFSA. I'm sure that during the Q&A session, we will be able to broaden the lessons learned. At the last conference of this, panel is in charge, will be moderated by Dr. Marcela Rodriguez. Okay, pardon me. I wasn't on the right page. Dr. Marcela Rodriguez is a veterinarian. She's an expert in food, health, and food technology. She has a master's in agroscience with a master's in public health and population medicine. And she has much experience with HACCP and BPM in swine and bovine. And she's an expert in AMR, mitigation, AMR, in the animal production industry. She's a consultant for many organizations of the private sector. Thank you. Good morning to all of you. I'd like to share two successful experiences from the private sector perspective. And I love this event because every time that we can work together or I can speak with you, you all say, oh, luckily the private sector is here as well. It's not something we see all the time. And this is truly enriching and the most enriching part of this experience. Well, first, This is an intersectoral panel that we have in Colombia for AMR, my expertise. And I'm going to just follow the order of what was requested of me. So first, the problem. If this has to do with AMR entails being able to response to AMR is developing a national response plan when emergencies arise. We are all required as a country to present a plan, but how do we do surveillance, monitoring, control of that plan? How do we all coordinate and make headway in the activities from one stage to the next? So in 2017, the intersectoral alliance, who makes this up? From private sector, we have the poultry producers, bovine, porcine producers, fisheries, the balanced food producers, the Chamber of Balanced Food, and the pharmaceutical industry. So after this partnership arose, we could at least raise our hand and say, industry is important in taking part. We're interested in taking profound action that will help collaborate with fulfilling this plan. But during the first few years, we entailed training, understanding the problem, the overall problem. But we realized that we needed to have more stakeholders on board to participate and to support initiatives so that it wouldn't only stay in the productive sector. And that is why, because of the much international cooperation we received, we held an assessment workshop of AMR. And this, we created a joint action plan as a result, where we have specific tasks and individuals that are accountable. And this is done by the private and public sector. And we saw with this action plan, we were able to sit down together, that is the public and private sector. And then we began to garner this trust and work together as colleagues, despite the area we worked in. And we were able to understand that although we had different needs, the strengths of each, we could provide we could work together to generate that single result, which is that the country make headway in this regard. So we meet on a monthly basis and we review the matrix. We identify the tasks that we've undertaken. If there's a gap because an expert isn't there, because we don't understand the topic, we raise our hand. And at this point, FAO is participating. ICA, for example, we include PEJO. So it's been a great success because it's helped us speak the same language to get to know the actions that we have without replicating efforts and optimize resources. And what's most important, it has shown us to learn to what extent our role stops and starts, and understand the role of the private sector, the needs of the private sector. So I think that this has been the greatest learning experience of this panel or of this association. When there's a change in government, it's always a challenge to be able to get the new government authority on board and understand what the plan entails, the strategies, and it's always a learning curve. But many of the government authorities that know the needs in depth and have garnered a relationship of trust, truly. So we also added academia lately, and we have research centers as well that are working on the environmental side, where we have a large gap because we don't have representatives from the environment, but we're making up for that. And we are leveraging resources from the Science and Technology Ministry that assign research centers to resolve these issues. And we bring them on board to create a common research agenda. So we still face many challenges, and I assume that we will continue to face them because we're all human beings, and it's always hard to find agreement and communicate when there's so many interests and indicators, and each ministry has their own data and needs. But we are trying our best and trying to fulfill the action plan. A lesson learned with this important example that I'd like to emphasize is that it is necessary to coordinate as an organization. With us, we use a private organization because they're always willing to support the logistics and to be in charge of convening the meetings, developing the minutes, because the public sector have different fronts of action, and they're not only aimed at dealing with AMR. They have no time, basically, with all the different hats they wear. So that way, adding the private sector allows the logistics to be taken care of, so they can focus on the actions such as bureaucratic actions, getting permits, licenses, or those types of activities that take time and that are required, nevertheless. So that has been, well, the greatest challenge, being able to coordinate as a secretariat, let's say. And then let me just quickly share an experience that we had where the problem was identifying if the use of diagnostic labs was used or not to mitigate diagnostic practices in the territory for small and medium-sized porcine producers. So I'd like to share this story because we received resources from ICART's international assistance to identify a sustainable solution to be implemented. So we were able to bring in anthropologists, sociologists, mathematicians, people that we didn't think could help us to draw conclusions and that would allow us to reach this territory and see what was happening, why we didn't use this diagnostic in different in small producers. We're surprised. We all thought it had to do with lack of access because there was no money for them to come on board. We identified that it was lack of knowledge. There's this gap because they didn't understand why labs were necessary. They weren't sure how to take a sample, how to send it or interpret it. They didn't have the know-how to make the decision. So when we went out into the field and were able to, with the anthropologists and sociologists, understand the reason behind the behavior of farmers and how they cared this autoconsumption market of swine production, we're able to understand the problem and the solutions. And perhaps I think that had we been in the capital sitting in our offices, it would have been impossible to understand this. So we said, okay, let's use the radio station at 5 in the morning or 4 in the morning when farmers are getting up, we're all getting up, and go out in the field and send messages such as use the mayor's office, or let's say the every Tuesday, let's say you can take samples at the local farmers market and find the way to reach out to farmers, take advantage of massive vaccination campaigns and vaccinate your animals. So after we did that, we realized that this didn't have to do with the lack of money or interest. It was just lack of knowledge. So that is where we insist that One Health is all of us. It's mathematicians, sociologists, anthropologists, vets, producers, the private sector. What's most cost effective? We think that prevention is. We prefer that than taking antibiotics. And we reduce the actual amount in pesos, and the ROI was able to be perceived, especially with the use of labs. So this is what I wanted to share with you from the private perspective. Thank you. Thank you, Dr. Rodriguez. Thank you for your excellent presentation. We are 60 minutes from ending this block. We still have to look at the specific recommendations that you can share and make with us. We had 2 minutes to do this. I'm going to ask an exercise, a synthesis exercise, to be able to make prioritized recommendations in a maximum time of 1 minute. We're going to begin with Gavin Peters, and they will share these recommendations with us. We'll speak about successful and not so successful experiences.
Thank you. I think I had given some of my answer in my previous intervention, but just to repeat, these would be my suggestions as it relates to the recommendations. And this is specific to the CARICOM region. Bringing all of the Caribbean One Health practitioners together for a 2-day think tank meeting. Let's talk. Identify One Health champions for each country in the region. And while it's a common concept employed by the veterinarians or the veterinary sector, other professionals have not had that experience, and therefore we have to engage them in discussions and increase their exposure to the concept. Countries should be assisted to establish One Health units in those countries, in each country. So that the objective of this is to institutionalize One Health, and so that you will be able to identify the areas of weakness and to be able to resolve them. So that we move it from the theory to the practice. And I would like to add in that, involving what my colleague mentioned about involving other, such as sociologists, anthropologists, all of those other sectors, not just animal health, plant health, and the environment. So thank you.
Gracias, doctor.
Thanks, doctor. I confess that what you're saying is truly important when you mention getting more champions on board. That's definitely a great idea. Dr. Rodriguez? I insist on the need to having we can say an organizer or coordinator of this process, an articulator, a secretariat, so initiatives can move forward. Someone that is exclusively dedicated to this and can support everyone else who wears different hats and is busy with their other parts of their jobs. So bringing academia to this process is important on the research side. And it's a true support for international cooperation entities. So I think we need to describe the needs of the country specifically and comment the initiatives of other entities that can support us, not only the ones attending this meeting, for example, but there are other organizations that deal with AMR in Europe, Asia, that are carrying out projects in their countries, interventions. So we need to optimize resources. And then finally, we need to generate a relationship of trust, of absolute trust among all the stakeholders involved. We always have to remember our roles and respect the official, respect the law and that official aspect of the group. Thank you. Thank you, doctor. So now we're going to hear recommendations of Dr. Romero. Okay, very short thought first. 13 million years ago, since matter was formed, since the Earth was formed, 200, and the Earth was formed millions of years ago, 400 million exactly. Homo sapiens came to be the only species that has survived since the beginning of time. So my recommendation is based on thinking about our Uruguayan Brazilian friend question: what is not One Health? It's not what, it's how, and it's really up to you. it's up to you to decide what is One Health, what is not One Health, and that way you can create efficiency, sustainability, possibly. It's not the easiest answer. It's not an easy answer. Rabies transmitted by dog bites was not easy to address. So we have to bringing vets to the Ministry of Health was easier than trying to resolve this as silos. And so let me quickly state that I invented something. Let me just take a minute to explain this. Okay, I did this, not the 4 C's, using the 4 I's, because it has to do with institutionality. So I invented a series of I's to make sure how becomes action. If you just give me a minute to go look them up. Even if you don't give me a minute, I'll do it as well. So, so Dr. Peters, Dr. Peters, we have done this before. We invited everyone to be in the same place. Dr. Peters, you were so right in what you're saying. So yes, it's a hybrid meeting, a hybrid connection. And everyone has said, finally, we are here from different sectors in a balanced manner. What a great challenge. And it was for you, Dr. Peters, and it is for us. Okay, so let's go on with the 4 I's. My first I is a process of, the first I is interaction. It's the first step. And it has 2 tasks. One is understanding. Many can, how to understand how we interact. Okay, food health, we have to start understanding what we need or what it is. Okay, then after understanding in interaction is acknowledging, recognizing, and it's recognizing us or acknowledging us. We get to know each other well. We acknowledge each other because due to our interaction. So I am interdisciplinary because I acknowledge myself and the fact that I can have different types of expertise, but I acknowledge or recognize that my neighbor also has his or her expertise. So the next I is interdependence. That's a hard one. When we become excited about One Health in the world, yesterday was great. Everything was pink, rosy colored. We're saying, okay, we're going to heaven. Those of you that believe in heaven. That was yesterday. That's the process of interaction and understanding. But from there to implementing something, there's a long road. So that interdependence entails accepting my what I'm capable of and am not capable of. Cysticercosis. First at the beginning, it affected animals, then human beings, and then there was diarrhea occurring. Then we knew it was a burden of eggs in the environment, and then porcine cysticercosis increased. We had to accept vets that we had to work with obsenazole, and then we could work with nicrosamine for when Listeria would go out into the okay, well, that's cysticercosis. But it's about this. It's accepting sometimes that public health depends on animal health with the avian flu, for example. That's not easy to swallow, right, Manuel? Okay. So how do we accept this? Accept ourselves as we are and admit that we need interdependence. So balancing, matching. It's an I in Spanish, but not an I in English. The interpreter just would like to mention it's equalize or matching. We have to be equal. And I didn't want to mention equity. I think that it's more like adapting. And that means that this is part of a prioritization process. So if I am able to match something, I prioritize things. So we're all going to work on preventing avian flu from becoming a pandemic and affecting human beings, for example. That's matching. or that's equalizing. And then we all do not need to be molecular biologists. And so it's adapting things rather than matching, it's adapting things. So being able to adapt means being generous and transparency. I have to admit what I can do and what I can't. And also interests. My PhD thesis was on stakeholder analysis. There were 12 papers in the world. This was 20 years back now, when I concluded my PhD. There were 12 published papers that mentioned stakeholder analysis in agriculture. Now, stakeholder analysis is used ubiquitously almost. And that means recognizing that we have interests, not convince ourselves that we all have the same interests. Yes, we have common interests, but that doesn't mean that they are all equal in priority among all of us. So that's why I think that adapting, we can't ask the private sector to adapt and educate children. As Dr. Yan mentioned, that's why the Ministry of Education exists, the state. So it's really naive thinking that we can really garner common interests. So that's why we have international organizations. That's why I have these meetings, etc. I know I'm going over my time, and I apologize. So my action is, so now the how. So I propose that after this understanding, after the stakeholder analysis, we have to create mobile leaderships. And mobile leaderships means that this common interest is the, what's that priority stake for the environmental leaders, for example? What's the priority for public health? But remember, these leaders do not work alone because they understand that there's an interdependence. So it means being a mobile leader, it means understand, and I know in my group session, everyone got mad at me, but this is the situation. And pardon me, Erica, it's a great opportunity I have to take advantage of. So this means that I apply the how with the stakeholder and the right, who has the right skills. So I have to hold a ministerial meeting. So that's the role of One Health, knowing where the skills are, not eradicating a disease alone, knowing that I have to have a One Health, focus at a leadership level where with the middlemen, the technicians on board as well. And you have to continue to go downwards, top down, to the regional and local level. Yes, I know. If we really think about, mixing the minister or bringing in the minister of the environment, the minister of health. So I think we have to work from a top-down approach. Okay, so we don't agree with Manuel. He thinks that this is not necessarily economically beneficial to all of us, but I think that it is. Loss of impact, for example, can become potential benefits, and costs are based on the sacrifice of general economic principles. But a cost-benefit analysis will lead us to this concept of One Health, which is looking at the problem. So I think that the result is as follows. Anything that we do with a cost-benefit analysis that has a good return on investment can be, we can use more sophisticated environments. This won't resolve the issue. We have to do a fiscal analysis as well, because although the problem isn't based on a cost-benefit analysis, it's the step that follows. This is much more complex. And so who pays for this? The loser, that is. And I'm going to close because it's just the tip of the iceberg. So this is a cost-benefit analysis. Can come into play, but we have to think about a fiscal analysis. So pardon me for surpassing our time.
Roberto Navarro, por favor.
Let us close with some recommendations. Roberto Navarro. Okay, from my view, I believe that both human doctors and veterinarian doctors have a similar function. The clinicians that examine the physiopathological aspects, and then we have epidemiologists from both areas that study the behavior of diseases. But above those, we have the social determining factors of public health and animal health and environmental health. And I believe there are tools. I did my master's in the Millennium Development Goals, and this helped build the SDGs. And there's an internationally accepted methodology that brings us all together, and we should take advantage of. And that is the logical framework, the log frame. This includes economic, political factors, cultural factors, and obviously technical factors to resolve a given issue. And I fully agree that we are in the paradigm of what One Health means. But this One Health is determined by all these aspects I just mentioned, which are the social determining factors, because in fact, everything has to do with what people do. So let us use that log frame. Let us come closer, take courses, because this will bring together all the different areas to solve a common issue. Thank you. Thank you, Doctor. And to end this part of recommendations, Dr. Manuel Sanchez. Okay, thank you. Let's see. To add to what Jaime was saying, we can add another identification of the issue. I said so yesterday. One Health is a network, and it is very important to be able to identify how we were questioning and examining that network, because zoonosis and antimicrobial resistance are not the same, and yellow fever is something else where agriculture has very little to do, but perhaps in influenza we can include agriculture. So there are other problems, biodiversity we talked about, and you mentioned the role of leaders, and I coincide with that equation. Depending on the issue, there are some actors that have to lead and push other factors, other actors and other networks. From what we said, I coincide with the importance of knowledge and expertise. With this intersectorial group of discussion, we need to tap all that knowledge and not ideology. These discussions must be very sound. And two more comments, Jaime. I do believe there is an opportunity. Well, I think there is a path that we have already taken. There are initiatives under the way in different countries, and I see this with very good eyes. But what happened with COVID and what happened last year in the region, working hard with public health and the ministries of health, I have realized that the CRC emergency were the ministries of health themselves in many countries, those that were worried and asking agriculture. So for some fora, this contact exists. Countries that, for example, that were not affected on the animal side, where the Ministry of Health, the Ministry of Health wanted to know what was being done, and they were asking agriculture because they identified them as the responsible party. And to clarify yesterday's discussion, there is an exchange of benefits, a benefit swap here, but that is not enough. We must identify what each one of the parties can contribute. We must map this, not just guide myself by what it will produce in my favor. No, we have to see the importance of applying One Health. Public health improves biodiversity and externalities, but we cannot just map it based on personal objectives or on one-sided objectives. Otherwise, we will get lost in this discussion. Okay. Very well, thank you, Dr. Manuel Sanchez, and I would like to thank all our speakers. You have shared a lot of information and actual examples that will help with the analysis and discussions for the afternoon. All I have remaining to do is thank you for your participation. And with this, we conclude this first session for the day. And we would invite you to take a coffee break now. To all of those that may have questions or comments, I am sure that our speakers will be able to to talk to you over the 5 minutes we have for a coffee break. Thank you.
Recording stopped.
Buenos días. A las personas que todavía no están en la sala, les pedimos que por favor salgan al recibidor.
For those of you who are still in the room,
Vamos a
we
recibir un
request that you
médico
please
médico, entonces les pediríamos a todos que salgan
go
y esperamos
outside
un
because
momento.
we're going to receive a medical visit. So we request that you all leave the room. Thank you.
Conference will begin in 2 minutes. La conferencia comenzará en 2 minutos. The conference will begin in 2 minutes. La conferencia comenzará en 2 minutos. Bueno, conference is now in session. Please be seated. La conferencia ha comenzado. Por favor, ocupe su asiento.
Hello, everyone. Once again, good morning. We will begin now
Recording
the
in
second
progress.
session of the morning. During this session, different international organizations will give you a bit more information on the plans and strategies they are working on within this for the operationalization of the One Health concept. I will start. Yoo-hoo! I will talk to you about what we are doing as a draft right now with the ICA's plan of action for the operationalization of One Health in the Americas. Next slide, please. Allow me to briefly explain what the agricultural health, animal health, food safety and quality program, hemisphere program at ICA. I am the new program manager. I have been here for 6 months. There are many people here that I have sat down to talk to, and we have come up with 4 major pillars for most actions and projects and initiatives worked on by the team. Focus on these 4 areas. We have animal health, plant health, food quality and safety, and safe trade through sanitary and phytosanitary measures. For me, this is an easier way basically to explain the information and what we offer to outsiders in animal health and plant health. We basically seek to drive and strengthen institutional growth of animal as well as plant health systems, focusing on good practices and on the preparedness and for emergencies and emergent issues in animal and plant diseases regarding agri-food safe and quality. We seek that the food is safe and healthy with traceability systems, good agricultural practices, and safe handling of food. And lastly, we have this is a big effort we are making in the area of sanitary and phytosanitary measures to facilitate safe trade through transparent rules based on science and to support countries in the adoption of recognized international standards supported by IPPF, Codex Alimentarius, and WOA. So here, this is the foundation that is cross-cutting, where we are trying to operationalize One Health to support the different pillars that we have within the hemispheric HFS program. So this is what we are trying to do, to work on One Health, but for this to support the actions we are undertaking in the different projects I already mentioned. Next, please. Okay, very briefly here. As you well know, we have the quadripartite, WOA, the FAO, UNEP, and a couple of years ago, they started with the theory of change to adapt and adopt, and then they came up with this series of actions. Natalia was mentioning that this coming October, they are going to put out some guidelines to help us as international and hemispheric organizations to continue with the practical implementation of this. And these policy actions basically are to prioritize One Health on the international political agenda, strengthen national policy strategies and health plans related to One Health, accelerate the implementation of One Health plans, national governance, intersectoral, multi-sectorial coordination mechanisms. Fourth, create intersectorial workforces to prevent, detect, control and respond to emergent diseases, strengthen and prevention pandemics, at the prevention of pandemics and threats at origin. The idea of this is to control a disease at origin instead of experiencing what happened with COVID, where in a few months it had spread throughout the entire world. So early detection and early contention at origin. Six, strengthen scientific knowledge and exchange of evidence. This is what we are doing precisely today, or yesterday and today, and to increase investment in strategies and health plans related, strategies and plans related to One Health. Next. Now, where is ICA with this plan of action? Well, when the DG assigned me the task to work on this event, we decided to work on a plan of action and bring to ground all this ethereal concept, and bring it to earth. put it into practice. So what we are seeking, and this is a very general objective, is to promote a permanent change. And we must see how to do this permanently. Diana was saying we have to go down all the way to children so that that becomes part of their genetic, their genes when they have, so they have that chip in them when they grow up mentally and emotionally. So the permanent change in public policies at an interinstitutional and community level to operationalize the One Health approach. This plan of action is focused on working in coordination and collectively with different strategic partners to to institutionalize, which is the word I used from Gavin. I love that, to institutionalize this concept. Thank you. So the team came up with three major objectives for this plan to make it more practical. First, to promote the creation of interinstitutional regulations and public policies. Secondly, how to continue to drive rural communities to think and work under the conceptual framework of One Health. And third, seek funding, money, and basically do lobbying with key partners and donors. So based on these three lines, this is where ICA wants to move the One Health concept. Now let us go one by one into these. When we talk about promoting the creation of public and policies and interinstitutional regulations, this means strengthening communication, coordination, and work among institutions and ministries. Here we see that there are several ministries involved and they're playing an important role: public health, agriculture, environment, economy, housing, industry, and commerce. Why housing? Natalia mentioned this on day one. Sanitation. There are things that rural communities still do not have. The garbage way, disposal, and this can become a good nest for many diseases. And with this, we are looking for other ministries that we must take into account to ensure better communication. Perhaps we will not make a change in the next 2 years, but okay, how can we move forward to start thinking down those lines? Diana mentioned the Ministry of Education. Find a way to educate children to think of this concept of One Health, to mainstream that idea. And as phase one, we have called it research. There are many areas that already know how to work on this, but in what we see, we want to identify barriers that prevent collaboration, coordination, and communication. Those bottlenecks define specific roles. And this we mentioned yesterday afternoon, the roles of the different ministries and other national institutions, and then develop an inventory, a mapping of strategic partners, of synergies, existing synergies in these countries. So it is important to have all that basic information. Next, I'm going to need a bit more time today. The second objective is encourage rural communities to think and work. Okay, how to do this? Well, we're thinking of sort of communities of practice where ICA or other institutions can work hand in hand and very closely and frequently with the rural communities. We need to see what information they need so that that information can climb up and have a two-way communication or interaction so that we can know that not only things come top down, we must think, because one way or another, if everything comes top down, well, it is going to be seen as something imposed on us instead of support or help. So we have to take the producers and farmers into account right from the beginning. So basically want to have a definitive transformation in the notion that rural communities have to begin working on small initiatives. As Maru said yesterday, we start small and then grow 1, 2, 3, 4 projects where we can start to have that interaction under this approach. And with this, we have common goals based on challenges, opportunities. We collaborate, we contribute, and communicate. What is this phase? The second phase is action, training and exchange of knowledge and work models. We have been seeing this yesterday and today. I see ICA and other organizations developing reference strategic frameworks for epidemiological surveillance, biosafety, early warning systems, generation of interinstitutional policies, something that we can offer the countries so that they can use it as a template to start working, so that they do not have to start from scratch. We can guide them hand in hand, but empowering them at the same time. And lastly, seek the execution or implementation of pilot plans within ministries and other national institutions and the rural communities, the beneficiaries. These are proposals that we are trying to work on. Next. And lastly, we have the third part, which is to do lobby in favor of investment among key partners, donors, and other stakeholders. We want to strengthen and diversify the relationship and partnerships with strategic partners, ensure acceptance and operationalization of this approach, and so that entities be mediators to promote the mobilization of resources between donors and beneficiaries. How will we facilitate that process? Well, this last phase I call collaboration, which once again is to do the mapping and effective identification of strategic financial markets and financing options at an international, regional, and national level. We have to adopt a consolidated resource mobilization strategy to help us in the long term. And I say there are organizations that have that are quite advanced in all of this. They already have a department for the area of One Health with specific specialists in financing and branding and etc. So we have to move to that in that direction. I believe that with this I end. Yes, I believe I did not go over too much. Thank you for your attention. And the idea is to continue learning and strengthening these plans. Thank you. Thank you, Jose. We met up for the few minutes I snuck from you. Good teamwork. Okay, we would like to welcome Dr. Andres Gonzalez, who is connected from Spain. He is the specialist, the senior specialist in livestock and animal health development. Andres has been connected early. Perhaps you could give us your presentation. Could you share your screen? Okay. I am not going to introduce them because I guess all our speakers are very well known to us all, veterinarian, PhD in Germany and heading many actions in the Americas and working together. Andres, go ahead. Thank you, Jaime and colleagues from MICA. On behalf of the Regional FA Office for Latin America and the Caribbean, I would like to thank you and express our appreciation for having considered us when organizing such an important event. I will try to be very concrete time-wise, considering the discussions of yesterday and the very interesting panels, and trying to add a bit to what has already been said. The presentation has been undergoing changes after the presentations yesterday and today, to not repeat, but instead add to what has already been mentioned. So thank you for the opportunity. Allow me to begin by saying that at the FAO, as part of the regional technical team for One Health in Latin America and the Caribbean, We have been working to officialize our work in One Health. We have heard how important it is for everything to have a framework and a guide. We always talk about interinstitutional cooperation and coordination, and sometimes it is good to begin coordinating internally within our organizations first, see how the different teams supplement what and help each other. In our case, for the Regional Office of Latin America and the Caribbean, together with our country offices in all 33 countries, members in the region, we have a guideline coming from the FAO strategic framework for the 2022 through 2031, where we consider 4 areas of improvement. As you can see, better production, better nutrition, better environment, better life. And in the area of better production, we have a subcomponent of One Health. This is not foreign to all the challenges that have been mentioned, because obviously One Health has to do with nutrition, with environment, with better living, but we have to organize it and keep it within a scheme that is as easy to read as possible internally, to then socialize it outside. So this became official with the countries during our last regional conference in the city of Quito, Ecuador in 2022. And the first progress as to operationalization, we have talked about operationalization a lot at this meeting, and that will be at the next FAO meeting in March 2024 in Georgetown, Guyana. And ICA and all those present are invited to participate. In our regional strategy, we have 3 regional initiatives. One for sustainable agri-food systems, another one for prosperous and inclusive rural societies, and a third one is for a resilient and sustainable agriculture. Obviously, they are cross-cutting all these, but linked to regional initiative 3 for sustainable work, where our regional team is working within the regional office. This is basically a preamble to what we are doing at the regional team. Very quickly, I would like to reiterate our compliance with a joint plan of action for One Health, the quadripartite, which we have been talking about, and the actions in the region obey the global plan of action for the implementation of One Health. And from here, we extract components that are relevant and in turn appropriate according to the needs of the countries in the region. We, as other international technical cooperation agency, respond to the requests of different countries. So based on that, we do the matching between the joint plan of action and the specific requirements that come to FAO in the areas of One Health. And with this, I would like to show you 3 concrete cases where currently One Health, and there are others, but we have selected 3 based on their relevance and based on their intersectoriality and what this represents for decisions and actions for the different countries of the region. Very quickly, let me show you here how, starting with the animal health component and One Health at FAO, how we work in the sense of organization. We have a head of veterinary services at our headquarters in Rome, and different sub-organizations within the animal health team that will facilitate this global, regional, national, and local link. We have the Empress Group that has to do with the global notification system, ECTAD, a center for cross-border diseases, of animal diseases, and EMC Animal Health. This is our emergencies. There's our 3 lines of support for One Health, basically related to animal health. So what do we ensure through this coordination? Well, that we prioritize things and we strengthen the veterinary offices preparedness, early response, capacity building, modeling to try to anticipate as much as possible any future zoosanitary, phytosanitary risk, and risk communication, which is so important because of everything we have been mentioning about creating awareness on actions, concrete actions in advance for this type of activity. So I will share three examples. Let us start with the most relevant currently in Latin America and the Caribbean, which is the 2022-23 avian influenza outbreak in the region. Avian influenza, the highly pathogenic avian influenza, has led to a lot of coordination and articulation among agencies in the region, not only in our global teams and their written guidelines, but in practice, how the technical teams have been able to interact to ensure the coordinated work regarding this highly pathogenic avian influenza outbreak in the region that basically forces us to prioritize activities and distribute activities among agencies to see how we can support the countries and how we do this as effectively as possible. In the case of FAO, we have been focusing on strengthening the veterinary services, better coordination among the different sectors, agriculture, environment, and health. Obviously, the outbreak, has a wildlife component, which is very important, which in most veterinary services has not been considered part of the important actions of these services, the day-by-day actions, not only at a national, but also at a regional level. Immediate assistance to provide essential or basic materials and support mobilization of resources. This has not ended and will not end soon. So this also is accompanied by risk communication and training materials using virtual tools to try to cover as much as possible in the region. And we are trying to reaching the rural communities to try to take advantage of technological tools and give them training in those areas where the internet perhaps is not as strong enough, or there's no connectivity or no electricity. So how can we ensure these materials reach the communities? And now, something very new we are doing is this next example. Let me say that, as Jose was saying, that he is learning since he was recently appointed as manager at ICA. Well, we learn also day by day to see how we can add to this. We have existing knowledge that has better work done in other areas or more actively, and that is the case, the progressive management pathway for biosecurity. We are working with our colleagues that worked in biosecurity of aquatic animals. Traditionally, aquatic animal production systems have strategies for the development and training in biosecurity that are much more advanced than those that work with terrestrial animals. So here we have a working group, very interesting, with aquaculture biosecurity, and we are facilitating and creating tools to gradually improve biosecurity in terrestrial animals to strengthen this synergy and not just work separately, but instead, every time we are going to develop a regional strategy related to strengthening biosecurity, we at all times must consider that our colleagues from aquatic medicine have very interesting tools that we have already started to transfer to terrestrial animals through this community of practice. That has already been a pilot in FAO in 2 regions in the world where the FAO works, and that we are starting to launch in Latin America and the Caribbean, considering concrete experiences we have had, particularly the case of working with improving biosecurity in the event or to strengthen or support the eradication and control of diseases in the region as the African swine fever in the Dominican Republic. I am starting to run out of time. Jaime, I'm almost done. No, you have already taken some minutes from the next speakers, but this is very interesting. Now, with the arrival of the ECTAD program in the region, this is very good news. ECTAD on the global sanitary security agenda seeks to build capacity within the country. Within each country, we provide the necessary support to set up these teams that will reach the local level much better in Latin America and the Caribbean. They are in the first phase in the zoonotic diseases and antimicrobial resistance. And there are 5 countries in this first phase, and this will be expanded to other countries. Phase 1 goes from 2022 through 2027, these next 5 years, as of 2022. And the program seeks to improve synergies and work between animal health and human public health. And I believe the recommendations I will leave for later if we have an opportunity to speak about this later. Much has already been mentioned, but let me stop here. Thank you. Thank you very much, Andres. Sure, fine. Yes, there is so much more to say. Yes. Okay. I would just like to remind you, although this is not on the agenda, we have a first phase, 10-minute presentations, and then we will have a series of questions similar to the panel discussions, the previous panel discussions, and then we will try to open up for questions from the audience. So you will have an opportunity now. We would invite Dr. Katia Martinez, very well known by all, veterinary and also representing, sub-regional representative of the World Animal Health Organization for the Americas, World Organization for Animal Health. Dr. Katia, thank you very much. Thank you. And I'm glad you were able to finish your other meeting right before, just in time for this presentation. Go ahead.
Good morning. As Andres said, this is a complex topic. There's a lot of information to share, so let me just take stock of the time I have available. And we're going to also speak about looking at this perspective from a global level down to the grassroots level. Now, we know that there are attendees here that have other expertises, and we don't tend to interact all the time. But we're responsible for health animal that has to do with animal health and well-being throughout the world. And we work in developing international policies with the end goal of supporting national policies world standards for animal trade and its and byproducts, and then working jointly with organizations of a global scope in the topic of One Health. Next, just some history. The organization began in 1924 with the onset of bovine pest disease, which was eradicated in 2011. This organization originated with the name called International Organization of Epizooites. That's why, and many times we're still called OIE. So we're based in Paris. We have regional and sub-regional representation of 5 of them that comprise the 5 representative offices on a regional level. And in 2023, we had 183 member countries. As I said, our mission is tied to improving animal health and well-being throughout the world, and especially with regard to protecting the future of humanity. Next, it's important to mention that this is an organization that has a mandate for countries to delegate their participation by a member that's nominated by at the country level. And then world delegate assemblies take place, and each member has the right to one vote. With regard to decisions, that's how that's the methodology. So just to summarize, a tripartite organization, and we know the story of our founding, first the tripartite, then the quadripartite, and now we move on to the developing of the plan, the global plan that is issued by the WHO. There's a similar development for development with FAO. And then we have the world strategy for antimicrobial resistance. And this is the work we've been doing in One Health, and its framework is focused on 4 specific areas or objectives aimed at the different countries. First, in managing awareness, raising awareness and communication with the public with regard to AMRs, or with a One Health approach. So the idea is to convey the work that we're doing in managing information, and then reinforcing national capacities for diagnosis and research, so that this could be based on a scientific information generated by each of the countries. So among the different aspects that arose with our strategy, within the framework, we understood that it's not only one sector that can face this situation alone. So that's why we have been establishing joint partnerships for developing specific actions focused on the different countries and their needs. And above all, in the strategic and global network to develop tools for this role. Next, then we also have done specific work with emerging and zoonotic endemic diseases, and interrelating this with the environmental health ministries, for example, and finding other experts that could support in addressing the emergency. We also emphasize strengthening health services in the countries. For example, WOA participated in developing national vet services in different countries and focusing on AMR. Next, given this focus, during the first, yesterday we mentioned that we work jointly with the World Health Organization, and with our organization, WOA, and it's called New Bridging Workshops. This is workshops that we hold in the actual countries where the PBS tool is used, which is the National Capacities Services for establishing policies, public health and sanitary policies. So we've developed these workshops and hold them to improve a joint effort. And as a result, we've identified that there are areas of convergence, and that way we can maximize the resources to be used. So as a result, this is the type of work we've been doing, the national bridging workshops. So as part of our actions, we also have specific policies, as I mentioned, where we have specific recommendations for safe trade. And this is used within the national policies and used for managing authorities at a national level. Next. Yet, although these policies aren't specific to a One Health focus, there are cross-cutting topics that include the criteria of One Health that are interlinked. Public health, for example, that is tied to zoonosis and antimicrobial resistance and food security, or food safety. And this is all tied to the topics we're addressing today. There's also a specific chapter that's on aquatic and terrestrial or land animals with regard to ARM. And when you decide, you can use it. They're broadly disseminated and used as part of the national levels at the national policies in different countries. Now, manuals. These are manuals for diagnostic testing, and it also defines the actual tests that serve as a diagnosis or that serve to diagnose the different diseases, and it's currently in use. We've worked on regional actions with the WHO, and UNEP is also part of this, FAO. So they are held on a monthly basis, and we have an agenda that we elaborate with the rest of the participants. And we also include ORIRSA, CBP, and CARIVET and CARICOM that are also immersed in this activity with the end goal of creating capacities and implementing national plans with regard to ARM. And we're also going to include wildlife and other fauna. Currently, we have a project that's funded by the European Union that converges 7 countries of the Southern Cone, and which have a specific end goal for antimicrobial resistance. And that has to do with streamlining national level action plans and joint diagnostic efforts and surveillance with regard to antimicrobial resistance. And within the framework, we've conducted different activities for planning. We also have the MPTF, which is it's a trust fund, a multiple associates trust fund, and it originated in Peru. And these are some of the tools that we've developed on a global level and that we've been working with for all of our activities for zoonotic diseases, and that are collected at a national level in a database to be able to have the specific information available. Then there are a series of guides that we developed that are available in 3 languages. First, we had it in English, but it's in the 3 official languages of the organization: English, Spanish, and French. And the objectives we've developed activities, workshops, communication workshops, also bulletins or posters that the different countries can use to raise awareness on the work that we do with regard to antimicrobial resistance and other activities dealing with emerging diseases. Thank you, Dr. Martinez, for your presentation. This is a process of just getting to know each other. And we're preparing for next year, and we know that we all are heading to Paris to cut the cake to celebrate 100 years of WOA, right? Yes. Okay, so we're going to now invite someone who participated when the first time the concept of One Health was coined, and this was the environmental sector. And curiously, it was formalized in a partnership just a mere 2 years back. I'm not going to ask Fabrizio about what happened during the 20 years because he's way too young, but those 20 years that environment wasn't present, but we're going to speak about the One Health strategy of the United Nations Environment Program. Thank you, Fabrizio. He's an MD by profession. So among so many vets, remember that you're among many vets in the room. Okay. Thank you, Jaime. Thank you, everyone. Thank you for the time that you allow me to make this presentation. I'm going to make a presentation from the UNEP perspective, the action plan that we are trying to better institutionalize on a country level. So this initiative is called Nature for Health. And what it tries to do is, on a global level, address environmental factors that are tied to country level approaches. And this is being implemented in different parts of the region. It's a progressive approach, but we want to give you a specific view as to how UNEP is addressing One Health in this with regards to this with this purview. So these are some areas that you are more knowledgeable about, or where the association of the environment and health is much clearer, where the, for example, foodborne and waterborne diseases that have to do with contamination, cross-contamination. We also spoke about pesticides yesterday. We also have we have AMR that has been addressed readily today, that isn't only tied to the irrational use of antibiotics, but also due to contamination that occurs due to poor management, or mismanagement rather, of antimicrobials, but that also affect the environment and people and animals, thus impacting crops. And others that aren't as evident, which is the environment and how is that associated with non-transmissible diseases. And here we speak about how pollution as part of this triple planetary crisis that I mentioned yesterday, plays a key role in unleashing different types of non-transmissible diseases that have to do with cerebrovascular diseases, cardiac diseases, cancer. So there's a connection not only tied to diseases transmitted through vectors or food, but with non-transmissible diseases. So that's another role that we're trying to emphasize based on on these aspects. So what is the Nature for Health program? So based on these pillars, understanding the problems before they are triggered or unleashed, by focusing on systems, we can generate strategies at a country level that will help face these problems from its environmental impact perspective. So it's about prevention. So it's preventing zoonosis before the transmission by strengthening environmental aspects based on One Health, and use a participatory systems-based focus where different stakeholders play a role when making decisions and help implement proposals by countries with countries that have a high risk of zoonosis, zoonotic diseases. So this is the chart that shows how we are organized. The secretariat is within the UNEP, and we work with a steering committee, which is a committee that basically provides a more strategic direction. And we have a technical advisory group with heads looking at scientific support and evidence accrual to measure impact, the impact of these activities and other implementing partners. The theory of change is also another topic, but I won't go too much in depth with this. But what it tries to do is look at the different actions that are mentioned here and reduce the impact of future pandemics or zoonotic diseases within the framework of the factors impacting the environment and degradation of the environment, climate change, land use change, biodiversity loss, animal husbandry, etc. And something that is also important to consider is that this strategy is also tied readily with the SDG, with the attainment of the SDGs. So attaining a One Health focus is directly tied to the Sustainable Development Goals. So we've established this temporal framework where activities are going to be executed to look at prevention from an environmental impact perspective, and that then are unleashed to impact animal health, human, and plant health. So this is going to be sequenced in phases. We're now undergoing the first phase, and then we'll select 6 countries to be able to embrace this type of strategy. So each of the different phases has 3 phases or 3 subphases. So right now, what we've done is that for the first phase, we requested or requested that countries make a call of expression of interest to send letters to explain why it's important to control environmental factors to prevent health crises in their countries. So we received 60 requests from different countries from more than 40 jurisdictions, sub-regional, regional jurisdictions, and some were even international. And then the technical advisory group looked at divided them based on with an evidence-based approach. They looked at those proposals that met the expectation and those that and were analyzed by the steering committee, who made the final decision as to which countries would be part of this phase, the first phase. So that included individuals that fulfilled the requirements and surpassed the expectations. These were countries that with a high level of being able to overcome zoonotic diseases. So after this first round, the first phase, which includes an assessment, a joint assessment with the selected countries, and I'm going to mention them in the next slide, but a joint assessment is made at for each country, where we include the areas that the country has been working on for the selected topic. For example, for Ecuador, which is attempting to identify preventable factors to prevent based on exchange of individuals with wild animals and fauna and prevent zoonotic diseases. So based on what the country's actually doing, the activities taking place, and the policies in place for that, because we can't lose sight of laws in this regard. And then that the proposals of the proposals in our call for expression are linked to what the country is doing and the different intersectoral approaches. So its funding is provided to execute these strategies. Now, the second subphase takes 2 to 3 years, and this is more of an execution phase. And after the country analyzes their priorities, we attempt to the greatest extent possible that the objectives contribute to the overall objectives of the program, which are the 4 that are listed, that include data enhancement, that data make the ties between biodiversity, climate change, and health more evident, and prevention, and it's tied to climate change and biodiversity, and then specific structures, that government structures of One Health. So these are the 6 countries that were selected for this first phase, and we see that Ecuador is included. Something to note is that when the call for expression was made, the countries were requested that from a planning perspective, where they presented their case, that they state 2 ministries that were going to be in charge of implementing these actions at a country level and be able to show that it was a collaborative process. In Ecuador, for example, this is led by the Ministry of the Environment with support from the Ministry of Health. But this also reflects the importance of intersectorality, because if we look at this on a country level, many involve agriculture, education. So that's another way of attaining an intersectoral approach. And then the idea is to be able to focus on the system and use the existing structures and involve other partners or rather stakeholders and think about the system in a way based on what we have, but also on what we can have, what is innovative, to be able to work in a preventive manner. The environment is a protagonist here to be able to unleash different results many times, sometimes they may be negative, but to impact human, plants, and animals. And next, stakeholders have to be related to a broad gamut as to who are the participants, because it has to be a process where everyone is involved, very participatory. So we also have to take into account activities that I mentioned that have to do with a theory of change. Activities will not be able to take place if we can't first show what the needs are at a country level. So that's why an analysis is done first, and then we operationalize and identify specific actions that can be taken from a legal perspective in the different countries, and then facilitate, or rather enable, by building skills building and lobbying or advocacy based on lessons learned. And then sustainability, which we spoke about, which my colleagues also spoke about, measuring. So we have specific publications based on the work we're doing in the countries currently. And last, this is an email where you can contact the individuals that are accountable within the Secretariat. And if you would like to know more about this initiative, please feel free to reach out to us. Thank you for your attention. Thank you, Dr. Ivan. To close, we're going to now ask Dr. Sanchez, very well known here by, well, he's been already moderator of, or he's been part of 3 panels, I think. While he arrives, I want to congratulate Dr. Katia. We always say that women speak readily. No, I think that we are the more loquacious ones, men, that is. So we can't buy into that stereotype, right? Thank you so much. Oh my gosh, it's so hard to replace you after speaking nonstop for 10 minutes. How can I even come close to you? Joke. Okay. So let me divide my presentation into 2 parts. I'm going to speak about the One Health policy approach of the WHO and the historic moment we're at right now, and speak about Panaftos SPV, which is where I work. Next. We have, this is our background, where the region has many success stories and much experience. And here we're going to speak about the WHO and the experience that we have with intersector collaboration in public health and animal health and the environment. So this was a very strong program for veterinary health at the WHO that has promoted these intersectoral efforts throughout the decades. For example, mechanisms, regional mechanisms, and different meetings, that interministerial meetings, the REMSA meetings, which is the Inter-American meeting of health ministers, health and agriculture ministers. That's been being held since 1968, and the last that was held in Paraguay, and we addressed One Health and the SCGs. And the ministers at this ministerial meeting that I mentioned, we also had representatives of the environment. And another intersectoral commission that we have is the Food Safety Commission, COPAIA, which has been in existence for more than 20 years. So there are mechanisms in the region, intersectoral mechanisms that are in operation. This is a document, a historical one, that is for public veterinary health, and that this picture that is before foot and mouth disease, the foot and mouth disease center. Well, this is what we had. And some years back, we discussed and approved at PEJO the One Health approach at the WHO, at PEJO, pardon. Then this entailed intersectoral collaboration based on different governance frameworks with the goal of improving prevention measures to surpass challenges and that impact the environment, animals, and human beings. And this also is promoted by interinstitutional work by different agencies and has 6 strategic guidelines. Next. And we've been discussing this. We do not necessarily follow this in a specific order, but these are the 6 areas of action that are most important that we've identified. One is to analyze the context in an intersectoral manner. We've spoken about relevant stakeholders and the problems that we would like to cover. That's important with regards to this mapping. And then the second strategic line that has to do with establishing governance mechanisms and establishing intersectoral panels to begin to to weave a thread in the country to promote these actions. Then we also have to have legal frameworks that will help us so they could be lasting in time. Then the 4th line has to do with intersectoral activities. And we have many examples that have been mentioned already, but we have to create and identify these activities tangibly to be able to execute them at a country level and regional level. And the 5th action line and the 6th one have to do with scientific support. We spoke about using knowledge and science to make decisions. And I'm sorry, I'm realizing that I have hardly any time left. Well, to support our policies and use technology because it should also be part of the One Health strategy.
I would try to go faster. We have the international sanitary regulation, mandatory for all countries. This is under the Ministries of Health. What this seeks is basically to prevent the international propagation of diseases or spread of diseases. I'm going to have to go through these very fast. And among the applications, we have to define work on surveillance and response, Article 5. When we work on surveillance and response, the regulation through capacities defined by the countries will define this intersectoriality. Then we have a monitoring mechanism that monitoring countries have to undertake every year through the Ministries of Health, and this is already mapped through 2 main capacities. Next. Capacity 12 that has to do with zoonotic diseases. And when we dwell on these, we're talking about intersectoral work here. So each country every year has to do a self-assessment of how they are doing regarding these competencies. The Ministry of Health has to meet with other sectors to see how well they are working intersectorially regarding zoonotic diseases. Next slide. And food safety. These are matters completely related to One Health, and within the international sanitary regulation, there has been work on this for many years. There is a score. Each country here has a score regarding these competencies. Now allow me to refer briefly to Panaftosa next. Panaftosa is a center created, well, we just celebrated 72 years. Here we are at the Panaftosa officers with our 72 anniversary t-shirt. This was created in 1951, basically to work on foot and mouth disease. A very important disease because it affects production. And then Panaftosa was joined by other programs located elsewhere as the one on zoonotic diseases that is part of Panaftosa since 1991 and food security since 2006. In 2014, Panactosa became a collaborating sector of WOA in veterinary public health. We are located in Rio de Janeiro, Brazil, where we can see this on the map, and either virtually or by moving to the countries, we provide support in different areas having to do with the veterinary public health or One Health. And I will give you more details of that. We are part of the Department for the Prevention, Control, and Elimination of Transmissible Diseases of Bajo. We have public and public and animal health officers. Before, well, we see that this is related to One Health. I think I have picked up on my time. Oh, no, not yet. Okay. We have four major areas: epidemiology, the one I coordinate, food safety, zoonosis, foot and mouth disease, and we have two laboratories: the production laboratory that was involved in the development of the foot and mouth disease vaccine, and now with the production of diagnostic kits, and the laboratory, the reference laboratory for WOA and FAO. And we have intersectoral governance mechanisms. I already mentioned some of these, like REMSA, but we also have REDIPRA. The meeting, the rabies program is to be held in Colombia this next month. This is another example of this intersectoral governance method, the mechanism that exists programmatically. Next, to the right here, we have collaborating institutions that we work in an integrated manner with WOA, FAO, in response to influenza. Now we are coordinating with Andres and his team, OIRSA, ICA, Caravet, LACAN, Ministries of Health, Veterinary Services, private sector, a very important actor in all of this, and the environmental agency. 2 slides to go. I made it with the animation because, well, rabies, bovine cysticercosis, basically all the avian influenza, food safety, laboratory, food safety laboratories, and integrated surveillance of antimicrobial resistance. And we can talk about specific cases later, but let me wrap up with some good news, because the next slide is the last one. I added it just right at the end, looking at the context of our discussion, because it seems that we're just starting, but this is a program, an interdisciplinary program that, in order to evade cases of human rabies transmitted by dogs, we have continuous vaccination campaigns to reduce the transmission and reduce that viral load in the animal component, and obviously in prophylaxis in the case of attacks. This is a whole combination, but basically this is targeted at controlling rabies transmitted by dogs, the variant of rabies. This is a success. This is and this is the last one. And thank you. Okay, now we would like to invite all the panelists. We are sure that, well, we would like to invite Jose Ordaz to come forward. And while he sits down, we saw the 3 major objectives of the plan of action with 3 fundamental actions: research, action, and advocacy. We understand what is happening. We move to action, but we advocate so that what is done is paid for. And action in territories, we would like to invite Andres to be connected, who talked about specific actions about health emergencies, and he talked about the 5 years in Latin America talked about biosecurity, and we talked about WOA with Dr. Katia, who explained what WOA is all about, its 100th anniversary, its connection with the quadripartite, and Dr. Ivan, who's referred to Nature for Health and its inclusion and connection with the SDGs. And lastly, Manuel, who gave us a scenario in which, as our DG was saying in his opening remarks, ever since the 19th century, veterinarians and doctors have been working on this. There is much more to do. We have a plant health specialist here also, and we promise you that the next time we have a meeting, we will have here IPPC here somehow. Okay, since I took up some time, if we make a sin, we have to vindicate. So using, well, I forgot what this was all about, the punishment or penitence, what it was all about. So I would like to invite you so that we be the first group to receive questions. How about that? But of course, you were prepared for that. So I have one single question, and I would like to turn you into recommendations. The recommendations you had already prepared, please send those to us via email, and we will share them with all. We are not going to cut off your recommendations, but what I want you to do is to focus everything you have prepared in one single concrete answer. And I can tell you, you cannot respond, oh, yes, we are working together because we coordinate in the quadripartite. No, one concrete action. You can use an example showing that when we work as international institutions, despite all those frameworks, despite all those agreements, it is easy, it is difficult, a concrete recommendation regarding that experience. And secondly, in that, incorporate add how to take that to the ground, to the territory. Those were basically the questions. Let us go in a voluntary order. All right, Andres, good for you. Go ahead. Thank you, Jaime. Very interesting for this panel of discussion. Congratulations to my colleague. Colleagues, I would love to be there with all of you. Okay, one recommendation, as you suggest, Jaime. Allow me to summarize. Something we have done and that has had a positive result and has generated rapid results is the fact of going out. Let's say if you go out fishing, go fishing for projects that perhaps have nothing to do with our areas of action and seek possibilities to come in with One Health. Let me give you one concrete example. We have a regional office of emergency and resilience that is responsible for the countries when there are volcano eruptions or tropical storms or landslides or mudslides, flooding, drought, etc., etc. Normally, what they do to help recover the means of living of the vulnerable population is to provide them with animals that are a rapid source of protein or seeds or other inputs or things that may help them produce food. We have found a possibility there to grow our work through projects that are not necessarily under our purview. Trying in this first diagnostic where we have to say yes or yes to see the beneficiaries of the project to understand how much of One Health is really reaching these rural communities. And this is a possibility. The second one is through mechanisms or existing entities, and I will mention three. I'm sure there are many more. The groups of organized women, rural youth, and indigenous communities. For example, we see to implement projects in indigenous communities mandatorily and out of sheer conviction. We need to have a prior consent report. This is the possibility to interact officially with the indigenous communities, and this allows us to integrate in this type of communication and awareness we work on with the rural communities and add knowledge related to One Health. This is just one example of how to maximize maximize our impact. The question should have been more concrete. You responded very well. I'm not going to give you another chance, but how to reach the rural communities was very good. The critical question, I guess, is what countries do not claim. I am part of it because, basically what I'm telling you is become organized. You tell us cooperate, but get organized. We have platforms, something very concrete. Think of what you do at all times. How can we get organized? I know this complicates or confounds the life for everyone, but who voluntarily would like to talk about that? Oh, Manuel. Okay, I will speak based on our experience. Communication, interinstitutional communication is fundamental. He is in Spain, I am here, but I would not mind being where he is right now. But that communication is very important. In the case of avian influenza or bird flu, we have streamlined communication with FAO. We are working on things together. Last week, we were in cooperation with OIDSA in the area of avian influenza. We coordinated for an intersectorial workshop. So basically, it's about talking. We should have a mechanism so that we can all get together perhaps once a month to talk, but at least bilaterally we do so. For example, with we work under the code, the WOA code, the terrestrial code. The chapter on avian influenza is essential for the work we do in countries, because this is the one that official veterinary services are regulated by. So we have to recognize that. Excellent, excellent, excellent. It was two minutes, so I didn't even count. No, it was 2 minutes, but I didn't even look at the clock either. Okay, let us see who else would like to speak. Go ahead. Well, Jaime, in line with what Manuel was saying, we should have something permanent result from this, a working group based on health, One Health, so that we can be in contact frequently, so that we are current and updated as to what the others are doing. That is one point. And the other one is that all of us that are leaving here today, take this message with us back. Spread the voice. Take this message to the national and subnational level so that this transformation can start now. When we think of how to work from now on. So these are perhaps the things we can do. And seek a next date for the next meeting to continue working with other speakers, IPPC, and more people from the private sector. And well, what about the producers, the rural communities that should be present? We should know what they have to say. There is much to do, many opportunities in the future. Very good, excellent, excellent, excellent. Okay, we have Katia and Ivan. Which one will go first? Okay, ladies first. Okay, all right. Oh, okay, fine. Well, look, I support what the previous speakers have said. We already have a platform, in fact, that has worked quite well regarding antimicrobial resistance that I mentioned in my presentation, and Fabrice was participating in that. Obviously, Manuel not, but we have Margarita, and from ICA we have Erica. We should define the contacts for each organization. We can define that right now and agree to a plan of action, executing a plan of action, because we ourselves would coordinate the plan as to how to move forward, what to do next in favor of One Health. We know all our agendas are very tight, and from now to the end of the year, it is even worse. But I believe this will be very important, not just to say we will meet. No, determine when and who will do what. That will ensure continuity. The quadripartite underway is monthly. Sometimes it is complex to participate. In fact, this week was one of them, and they most had to cancel because they were coming here. Well, we have advanced, but I'm sure we can continue and we can add other matters that we need to work on, not only AMR. Perhaps Ivan and then Jose, and if there are questions, please pick those up. Yes, I believe that the mechanism is fundamental. I was mentioning that with Daniela right before the beginning of the session. Something important is that we commit more formally to the sectors that will collaborate and encourage ourselves to get to know each other. And it is very difficult to promote intersectoral work when the sectors don't even know each other within one same country. So perhaps getting a way to approach each other and how we can articulate in the field is very important. So this concept of multisectoriality has to be based on one of the principles that was mentioned, which is communication. And obviously this has to be include organizations, but at the same time, the implementers. Okay, adding a bit to this, part of that actual commitment could come from the fact that many organizations, for example, in my program, we have no one specialized in one subject matter or in another, much less on one health. But if we have someone to be a champion of one health and train that person and give that person the necessary tools so that the openness is developed. Talking to Katia yesterday, we do not all have the flexibility of having that one person, but moving towards that, perhaps that could show the commitment or demonstrate the commitment we have to implement One Health. Okay, thank you very much. I like this very much. We have heard excellent ideas. We have 10 minutes, maybe 15, for an internal round. We will apply the 45-second clock to them for responses. Okay, 1 minute, fine. 1 minute, so that we can all speak as much as possible. For 15 minutes, we can have 15 comments, questions, including the questions and the answers. At the end of the minute, you look at the clock, you applaud. End of the story. So go ahead, Dr. Keaton. Hello. 2 comments. One, I believe, was very clear. We need that permanent space for exchange among countries to see, examine the problems, how we can solve them, and see which of those can be applied in one country or not. That is one. And the other thing, I know this is utopian. I recognize it. But I believe it is wonderful for organizations to get together, that we have a single window to address these issues. Because what I see in the presentations is that there are some areas that are overlapping. There are resources that applied in different countries and different organizations that seek the same objective. And if these organizations were coordinated, it would be much more efficient and all countries could have better access. And I advocate permanent space resulting from this meeting. Thank you. She reached exactly the minute. Dr. Roberto, yes. I have another comment and as well as a question. And I'm talking about Mexico. I do not know about other countries. But we still need that proximity of organizations within countries. I remember PAHO before they had the veterinary public health services very closely linked to the veterinarians in country. Now they have a person, but basically is locked up in the Ministry of Health or the Secretary of Health without any contact. At ICA, we do have close contact as well as with OIRSA, but in the case of FAO, I have contact with Andres and more regionally, but not with the FAO people in Mexico that are collaborating, much less with UNEP. I have even no idea. I'm sure they are there in Mexico, but there is no contact with the veterinary services, and I would imagine they do not have these with public health either. And these are important things, but we need that. All right, public, 1 minute, 1 minute. Remember that is your task. Okay, tell me if virtually we have speakers requesting the floor. I am tough. If there is someone virtual, this is your opportunity. Three comments quickly. The possibility of having the experiences published, and the other one would be to remember occupational health and have the occupational health specialists at these events. And the third one has to do with the opportunities that countries are generating. There could be a national plan on One Health, as we're trying to do with Brazil. Is there anyone else virtually? Questions, comments? Okay. We would like to ask if there are any reactions regarding the useful comments and reactions of the audience. 1 minute also. Well, hey. Well, at PAHO, we cannot have someone personally at each office. We have an office in each country, and we work, for example, with brucellosis in Mexico. We have been working on this recently with our colleagues in Panaftosa that have been working through the office. But our colleagues in the transmissible disease department, that is our focal point there. And you have to be aware of the public health activities we are undertaking. What the colleague was mentioning about occupational health, well, the truth is public health has not been clearly represented here. There are many things we have not discussed. For example, how to work with avian influenza on the human side with unexpected cases that are related to occupational matters. Very good, very good. 1 second, 1 second. Okay, comments, Andres? Anyone else? Andres? Dr. Navarro, although we are not there in person, it is somewhat complex here. And in fact, I came to meet Fabricio here. He's based in Panama. We had met each other virtually through the RAM meeting, AMR meeting who I mentioned, but we have tried to strengthen this virtually even during the pandemic, meeting with the people of environment and those of communication and the focal points. We have focal points for food safety, food of animal origin, veterinary products that are responsible for our AMR and the wildlife. So there are times when we bring all these people together when they are interested in, when they might find of interest to work on this together. Excellent, excellent. Ivan and then Andres. Okay, very quickly to comment in the case of UNEP, for example, the presence at the country level as such is not being physically present as other agencies that have greater capacity and physical offices in different countries. For example, in the case of UNEP in Mexico, there is a sub-regional office. So I do believe it is important that we approach our counterparts in the country, and we have that bilateral need to exchange initiatives and to better understand our capacities and how we can support each other. Because at UNEP, we also have sub-regional offices that try to work on problems, regional problems at a more macro level. Excellent, Ivan. Andres, go ahead. Yes, thank you, Jaime. One reaction to the comments that have been made so far. For a One Health meeting could be sustainable and prevail over time, it needs to have a clear, concrete agenda. The subject matter is so broad that if we do not decide what to talk about and how long, we may get lost because of the broadness of matters to cover and the inability of the different partners to participate in each one of these. So we need to be more concrete in matters and have perhaps terms of reference that are agreed to by consensus by countries and international organizations. Thank you, Andres. We have another comment in the meeting room. Question: what do you have to say about the creation of a training center in each country with the support of the services in the countries? In Argentina, we had the Sebasep Center, which was very successful. It no longer exists, but based on what we are talking about, perhaps this is something we could encourage. Excellent. Comments, additional comments? Doctor? Lenore?
Thank you very much. One of the comments made yesterday in our work group was the problem, as I see it, of our not using the COVID-19 pandemic to promote One Health and to identify COVID-19 pandemic as a One Health event. In fact, there was someone in our group who was questioning whether COVID-19 was a One Health event. So I think we need some kind of one-pager that we can use for policymakers and also for the public that talks about what One Health is, what it is not, and how we can use that concept to help us to anticipate future pandemics and to be prepared, not only for pandemics, because remember, One Health in chronic diseases has to do with the food supply as well. So let's not forget that in terms of chronic diseases. Thank you.
Perfect timing. Great. One comment virtually from Dr. Rocio Campuzano, Mexico. She says, one good way to work jointly is planning to address emergencies and have joint workshops among the areas involved in simulations and drills in certain areas. Now I lost the order out there in the back, Alejandra. Thank you. Greetings, everyone. Going back to what was analyzed yesterday in the panels and today also, and the discussion of Group 4, the yellow group, and in that search for interdependence, part of the we have to open up our minds and put all our cards on the table. I believe it is necessary to consider, in view of all the technological advances in artificial intelligence and all those things, and seeing this a whole generation already using technology, we should have a platform, perhaps a web, where we can say, okay, a One Health platform. And we can add successful experiences, events, memories, memoirs, and we can use disseminate this through social media. I know you want to cut off my seconds, but I can help you gain back some time. But let us come with concrete things where we can, as Jose said, so that we can bring this to ground instead of just looking for One Health, and we have One Health on the WOA website or on PAHO website. No, one same platform. Thank you, Alejandra. Dr. Katia? Dr. Navarro again.
Sí, de hecho, uno de los puntos como el que
Yes,
tocó el doctor
one
de
point similar
Argentina
to what the
es
doctor from
que,
Argentina
por
mentioned
ejemplo,
is that, for
la OMS
example,
tiene
WOA
algunos centros
has some
de referencia,
reference
así
centers
como centros colaboradores,
as
y
well
en
as
estos se han
collaborating centers,
identificado
and
algunos que
they
el
have
Sebasa era uno de
identified
ellos,
some.
solo que
Sevasa was
se han
one of them,
retirado por
except
el
they have
tema de las
withdrawn.
capacitaciones.
For
Podríamos
training
validar con
purposes,
algunos
we
de
could
ellos si pueden
validate
hacer
with
algún
some of
plan de
them if they could
educación
develop
que
it,
pueda
a curriculum, what
hacer
have you,
entrenamiento o
for
capacitaciones
training
específicas para el tema de una salud.
in the area of
Eso
One
sería una de
Health.
las cosas que
That would be
podríamos mencionar.
one thing worth mentioning.
Doctor Roberto.
Dr. Roberto. Okay, taking advantage of these comments. Fernando, excuse me, from Argentina, and from Dr. Campuzano in Mexico with the FAO in Chile. We have advanced somewhat in a center of excellence for training in our countries and other countries, taking advantage of the installed capacity. ICA that is aware of this, so that in the future we can once again we could have the center, but there are other modalities in the Americas, but have been exploited in Europe, for example. Perhaps Andres can comment something. Excellent. Last comment, apparently. Oh, someone else in the back? Okay, three last speakers. Go ahead, Manuel. Well, Panaptosa is a training center. We have workshops in other countries. The last one was a few weeks ago on the management of high casualties due to avian influenza. There are regional centers that are doing this. Much has been said about what One Health is. And something that has to do with environmental health, animal health, public health, that affects more than one sector is something that we should consider including. It is not, we're talking about 4, 5, 6 actors. There are other things that happen between or among 2 or 3. So these are some other things to think about. Very good. Oh, yes, out there in the back. Diego Quiroga is requesting the floor via Zoom. Okay, Diego Quiroga, go ahead via Zoom. Thank you, Lourdes. Thank you. Good afternoon. Thank you. I am very happy and I have taken note of the commitment to invite IPPF for next time. I believe this is very important as a part of the NPPO here in Argentina. We should intervene with a plant health in One Health also. The way to move forward is by participating. So I thank you very much. And with Argentina and COSABE, we are willing to work together. Thank you. We have a section virtually. I am arbitrary as so Dr. McAllister Kavut. Go ahead, McAllister.
Excellent.
Jaime, can you hear me? Yes, perfect. Okay, fine. Thank you. Well, good morning, everyone. But I would like to say something specific as follows. It is very important that from that multi-sectorial idea or nature that all participants are defending very brilliantly. It is worth highlighting that we need to develop or move forward developing public policies, national public policies, or in the case of the Indian community, these could be regional, and to promote national or regional regulations or norms related to One Health, because that way we ensure the participation of multiple authorities, and also because norms and public policies ensure 2 things: the allocation of resources from national budgets in the different countries, and the active participation of authorities. That is why public policy instruments are very important point, are very important tool. Nobody has applauded. Come on, thank you. Okay, we have a few others over here. Well, thinking of the innovation of this event, we would suggest that members of the traditional communities be present at these events. And that we have environmental NGOs and others, and the people from protected areas thinking of that connection between sustainable agriculture and the need to preserve biodiversity in our protected areas. Andean community, Dr. Caña. Thank you very much. Congratulations for all the presentations, very interesting. Adding to what my colleague was mentioning, Dr. McAllister was saying, I would like to know whether you are aware of any country, any economic bloc that would be working on regulations, intersectoral regulations for these matters related to One Health. Dr. Tanya, we will not respond to the question right now because you got one step ahead of us with the afternoon workshop. You will talk about that in the afternoon, just as we promised that we will take no comments. Well, oh, were we expecting one more comment from you? No, Jaime, thank you. I would just like to say that a good part of the capacity we need and make available to the international community is already within the veterinary services in the region. And that is what will help us strengthen the work being done through international organizations. Thank you very much. Okay, I hope I have given everyone an opportunity to speak. I would like to thank the panelists. As you must realize, we all know each other. There are very few of us here. We come across each other in the same events. And we have a new actor. And when we talk about innovation, we talk about an event where we have seen more people than usual. We have the commitment of engineer Quiroga. IPPC will pledge here. Okay. And I echo those that have followed us on social media and Zoom in all three languages, and we have ensured that One Health be open to all. Thank you very much to all of you. I apologize if I have exerted pressure. We know each other. If you get upset, invite me to a glass, to a beer. And I would like to offer the floor to our manager for the closing remarks. Now, we have concluded the hybrid event of One Health event. I would like to warmly thank all of those that have joined us virtually. Thank you, Andres. Very interesting information. We will continue to work together in this matter. Thank you. And in many others. I know we have a long list. Excellent. Allow me to take advantage and thank the AHFS network that has joined us virtually. This AHFS network is a network of experts at ICA regarding animal health and food safety throughout the hemisphere, which together with them, we have worked very closely with the countries. Here we develop documents, they help us, they distribute the documents to strategic partners nationally in each one of their countries. There are about 50 in this discipline working together in the Americas. So thank the AHFS network helping us so much in all aspects of this event. An applause for the AHFS network virtually. Okay, perfect. Okay, we have ended this session. Now those in the meeting room will head off to lunch. So enjoy your meal. the same meeting room we were in yesterday. And then we will come back to this room to give you the instructions, and then we go back to our breakout rooms for the afternoon session. Thank you very much.
Entonces le quiero pedir al
Allow me
Recording
to
stopped.
ask